tuberculosis, known heart disease, history of blood transfusion. History of travel is very, very important, especially if you want to know whether he has contracted the disease from some endemic region, high-risk behavior, and animal and vector exposure. This is important because, as we all know, that the infectious diseases are often vector-borne, and if we can pinpoint something, then we will be helped in our diagnosis. After we have taken a meticulous history, we may or may not get a clue about the diagnosis, and it is very important to examine meticulously. The general survey in itself will give you a lot of indications if done meticulously. So if you get lymph nodes or a sternal tenderness or some particular incriminating rash, you may understand that maybe this person is suffering from this disease. Organomegaly, of course, is very, very important. Evidence of respiratory, cardiovascular, neurological and musculoskeletal involvements are to be sought. As I was saying, syndromic approach is very important for diagnosis pyrexias. This stands also for prolonged fevers, though all those syndromes that he had mentioned will not be applicable in case of prolonged fever. I have mentioned those which you need to note. That is, fever with hepatosplenomegaly, fever with lymphadenopathy, fever coming with joint symptoms, arthralgia or arthritis, and fever with rash. So, fever with lymphadenopathy can happen in TB, HIV, brucella, leishmania, scrub typhus, even systemic fungal diseases. Non-infectious causes like hematological malignancies and connective tissue disorders are also coming with lymphadenopathy. Fever with hepatosplenomegaly also has a big list. In fact, I have not been able to write all of them. Here also, both infections and non-infectious causes are to be kept in mind. Similarly, the syndromes of fever with rash and fever with arthralgia have specific clues. So, I come back to the examination of our case. As you know, that patient was suffering from intermittent fever for 3 months. And we examined him and we found that he was thin-built, his vitals were more or less normal, though his blood pressure was 90/60 with a postural drop. He had mild fever and there was some hyperpigmentation over his oral mucosal surface. On examining further, we found occasional scattered crepitations in both his lung fields. The other system examinations were non-contributory. So here I take the opportunity of describing how, after you have examined your patient, in any case of prolonged fever, you would go on with the investigations. I won't go into the details because sir has already enumerated them. So we start with our obligatory investigations of the CBC, doing the MP and renal hepatic function tests, electrolytes. The inflammatory markers, of course, they will give you an idea. Maybe if they are very, very raised, you have something that patient may be suffering from some connective tissue disorder or some malignancies like gammopathies. Serological tests are nowadays available for most of the infections that plague the patients of the tropics, and notable among them are the malarial, the leishmanial tests, leptospiral, scrub typhus, enteric fever tests, etc. About enteric fever, I must tell you that the most common test that has been for ages being done is the Vidal test. Is not a very specific one, and we need to check the rising titer to say that it is significant. Culture of the organism, that is culturing blood or various bloody fluids is very important if you fail to come to a diagnosis from the initial set of investigations. If your patient has come with some kind of encephalopathy or a disoriented state, you may have to go for the CSF analysis. If you diagnose presence of fluids in the pleural or peritoneal cavity, study that. You have to search everywhere to find the cause, the root cause of the fever. Molecular diagnosis are helpful nowadays, and it is helpful to pinpoint certain infections, not all. If your investigations regarding infection is non-contributory, you have to look elsewhere and go for the connective tissue disorder profiles, the enzyme CPK, LDH, and the protein electrophoresis. These are generalized tests that I am mentioning, which is done as an algorithmic approach for any case of PUO. But please remember that this list has to be individualized in your patient depending upon the clues that you have got from history and clinical examination. Imaging is very, very important. So it involves imaging of the chest and abdomen and the heart. If you are suspecting specifically a vasculitis, then we go for imaging of the vessels. If all tests are non-contributory, in the guidelines it is said that for a case of PUO, you should go for a PET scan wherever it is available. Especially it is helpful in those cases where you get a very elevated ESR or CRP. So what investigations we did and what it revealed in our case is that he had a anemia to some degree. Otherwise, his total count and platelet was adequate. The ESR was 78 millimeter, which is raised. His other workup was non-contributory regarding urine, ECG or seropositivity. It was not there. This is his chest X-ray. You can see that bilaterally scattered opacities were noted in both the lung fields. Mantu was positive. The sputum was, just a second, please. Okay, let's go on with whatever was. Now, when we did the ultrasound of his abdomen, we were very interested when we found that bilateral adrenal glands were enlarged, and we went for a CCT abdomen to further characterize the enlarged adrenal glands. And as you can see that the CT scan of the adrenals depicted bilateral mass-like lesions which were on both sides with peripheral enhancement. So to summarize, our patient had fever, had hypotension, some mucosal pigmentation, lesions in his chest, and CT scan showing bilateral enlargement of adrenals. So we went for his hormone study, and it revealed that his cortisol was much lower than normal and his ACTH levels were raised. So in this case, what is the DD of such a case presentation, especially when your imaging study is showing enlarged adrenals? So this patient had adrenal insufficiency. However, what was the etiology of the adrenal insufficiency and fever, we had to find out. So commonest cause is tuberculosis in our South Asian region. However, we must not forget that that is not the only one. The patient was prescribed ATD and oral steroid. It was prescribed, unfortunately, without going into a tissue diagnosis, on the basis of his clinical presentation and the fact that adrenal TB is very, very common in our country and must be also in Bangladesh. So he was prescribed ATD and he came for follow-up, and patient's fever subsided and weight gain ensued. Please remember, he was also given his steroid replacement. But what happened is, when after 6 months his ATD course came to an end, he stopped all medications and his fever recurred. So now we have to work up the patient again. We advised a second CT scan and it revealed that still there was these adrenal masses present. So they had not subsided despite the patient receiving a course of ATD. So now we come to the next step, that when we have to decide for invasive tests in any case of prolonged fever, and here you can have to take tissue from whatever is available in your hands. So it could be a lymph node, it could be a bone marrow, liver, kidney, or if there is a skin lesion, then you have to biopsy the skin. And it has in various series of PUO shown that up to 35% diagnostic yield. Now coming back to our patient, the FNSC from the adrenal mass in our patient revealed this picture, and it was stained with PAS, and it said that degenerating histoplasma capsulated organism was found in a necrotic background. So the provisional diagnosis in this patient was a case of adrenal histoplasmosis presenting with Addison's disease in an immunocompetent male. I present this case because dealing with fevers, tropical fevers, is very difficult, and sometimes you may be misled. So instead of going on to any empirical therapy, it is very important to confirm the diagnosis. Since I have only 1.5 minutes, I think I'll skip the next case. I just want to summarize that young lady, another patient of prolonged fever, she came with, let me show you the chest x-ray, some lesions in her lung which are rounded in the lower zones, and the CT scan revealed a mass-like lesion which was FNSC, and it showed branching filaments in a background of necrotizing inflammation. So this is the picture of the FNSC, and the diagnosis was nocardiosis. So this pair of cases which we found, which were very uncommon cases of prolonged fever, and we should keep them in mind. What my message is that of course the common things will come first, but we should not forget that there may be some organisms which are now being diagnosed better because of improved diagnostic facilities. So diagnosis of PUO is a challenge, and clinical signs and symptoms are often subtle or overlapping. Serology-based tests often have problems because of a high baseline titer, and there is cross-reactivity. So with all these problems, you may have to resort to invasive tests for confirmation and further management. So I thank you for your patience.